Good morning, everybody. Welcome to our public board, our first public board for 2023. Really delighted to welcome colleagues and Tony Halliwell, who's our sharing our patient story today, but we'll be introducing that shortly. Also wanted to welcome governors who are observing us today, and hopefully you'll have a really good opportunity to hear from the board about the issues of the day. And a particular welcome to Robin Burgess, who's our newly appointed non-executive director. So Robin has very kindly agreed to be sort of thrown in at the deep end, because we only managed to get through all the process literally, I think, by yesterday. So with all the effort from all colleagues to get him on board, we have been able to invite him to join us, and he's scrupulously gone through the papers as well, which is great. So warm welcome, Robin. I know we'll do sort of introductions and things in due course, but just wanted everyone to know that you were with us today. And just to remind colleagues, Robin is replacing Maria Wogan, who left us at the end of December, and a particular thanks to governors especially because of the huge effort to do and manage and oversee the non-executive recruitment process. But more about that later. So that's I think the start that everything I need to cover off at this stage. Just a reminder that the meeting is being recorded and being observed, as I've already said, so it'll be available for viewing on our website afterwards. And in terms of apologies for absence, I don't think we've had any today. Judith is with us, albeit she's overseas at the moment. So, but I think a connection could be a challenge. But really pleased, Judith, you were able to join us. So can I just check whether there were any declarations of interest for items on the agenda? We obviously have our register of interests available in the board papers, but any specific interests in relation to items on the agenda? Okay, none that I can see. So do obviously put your hand up, or preferably using the facility in the menu, but otherwise either through the chat or physically, but it's always obviously harder physically to see that. Okay, so minutes of the previous meeting, which was paper A on the 24th of November. Can I check whether colleagues are happy that the minutes accurately reflect the meeting that took place on the 24th? I think there is nothing to the contrary, so I'll take that as approved. Are there any matters arising that aren't covered on the action sheet? Okay, none to bring to our attention. So we move on then to the paper B, which is the action sheet. And that indicates there's a few items there which I just wanted to reference. The first item, review of strategic objectives, that is completed. The next item, which was really, if we recall, we touched on the resolution approach and the potential for considering whether that's useful in the context of our governor processes as well. I think, Richard, because this is not going to be something we're addressing immediately, I wonder whether we just put a specific date on our on the sheet. You've indicated October or December potentially, so perhaps we just leave it with a date on so that we don't really worry about it until the date is due.
Agreed.
That's okay. And then the Freedom to Speak Up 6-monthly report, I think you were having a conversation with colleagues about that. Do you want to comment on that?
Yes, happy to. So I have engaged with Beth, Angela and colleagues. We have now got Beth coming to do an annual report to the board, and there's also an opportunity to have a more detailed discussion in development session 2. And obviously routinely Beth is attending the Q&S Quality and Safety Committee meeting and to provide assurance throughout the year. So we'll update the work plan, Krishni, to reflect that new approach.
Great. Thank you very much, Richard. That's really good, helpful. And I think the only other actions relate to the actions that came out of the complaints and TAL's report. And I think there's obviously quite a lot of activity. I wonder whether that really now is back to the Complaints Review Committee to manage, but report back through the report to the board. And I believe we've got, is it you, Julia, that's on the attends that committee anyway. So if we can just ask the committee and the committee chair to make sure that those actions are taken forward. I think the only thing we do need to be focused on is, the sort of the report back that the scores have been falling and things like that, which I do think we need to be looking at and understanding. My sense is that there is actually a reduction in the number of pieces of feedback that we get. I think that's been reported regularly, and whether that has an effect as well. But so helpful to have the update, but if we can now leave that for Complaints Review Committee to pick up and report back, and Julia through her attendance as well. Thank you very much. So that's the action sheet. Any other comments? I think everything else is completed. And any comments about that or the annual forward plan, which I think probably Richard, you and I need to just refresh for the coming year. Anything else? No? Okay, thank you very much, everybody. So really delighted now to welcome staff members and our patient Tony for the patient story, but I'll ask Jean to introduce it. Jean.
Thank you, Chair. So we've got the diabetes team, or some of the diabetes team with us today. And the reason for that is because diabetes work that is undertaken across the county is so significant and has such a massive impact on so many people's lives. I thought it'd be really helpful for the board to hear, in particular, a story from Tony and some further narrative from Kelly and Lindsay, who are here. So Lindsay is the head of the pathway. So diabetes pathway lead, and Kelly, as I think she's introduced herself to some of you, is one of our senior diabetes nurses. And many thanks again to Tony for agreeing to come along and tell his story. So I'm just going to hand over to Lindsay, first of all, just to introduce the story and just provide a little bit more context about the service. So over to you, Lindsay. Thank you.
Thank you. Yes, Tony volunteered to provide a story after attending one of our Daphne patient education courses. So Daphne is designed for people with type 1 diabetes. It stands for dose adjustment for normal eating. And I sometimes think it ought to be renamed, really, because I think it's much more about than just food. It's about living a life with diabetes and being able to live a normal life with diabetes and manage your diabetes alongside that. I've got quite a lot to say, actually, but I think we ought to introduce Tony, but I can't see him on the screen. Is Tony, are you there, Tony?
I'm definitely here. Yeah,
You're definitely there. Okay, marvellous. Thank you very much. Tony, because I can talk on forever, do you want to start off with your story and then we can talk a bit more about our services afterwards?
Yeah, sure, by all means. And thank you, and hello everybody, and thanks for giving me the opportunity to talk. It's very concise. I'd previously done Daphne as it was back then, prior to it being adjusted just for this was a pump specific course I went on, and I think with everything in life, complacency kicks in at a certain point in time. You become used to the routine, and you think that you've hit a status quo. You think that, okay, my sugars aren't quite as good as they could be, but they're not causing me too many problems. And life gets in the way. It's difficult. I don't know how many of you, or if any of you, are diabetic, but it's a pain. And so when I was invited to go on the course, I thought, you know what, I will. It's just going to give me that mental kick to readdress some of the things that perhaps I've just let slip by the wayside. The course was fantastic. I mean, in no small part due to the people that were delivering it, because they delivered it in such a way that it was accessible for everybody. There was a wide range of people on the course. They had different backgrounds, different experiences, and different lengths of time suffering with the disease, and everybody was treated equally. Everybody was listened to. Everybody's statements were valid, whether they were correct, incorrect, ill-assumed, presumed. It really didn't matter. Everybody was listened to, and because of that forum, because of the way that it was delivered, it made you listen. It made you take on board what was being said, and it made you realise that actually doing these things periodically educate you in such a way that it becomes part of your routine. Over the course of the course, my HbA1c dropped, my 90-day averages dropped, my time in range increased, and increased significantly, from 45–50% up to over 70% over a 14-day period, which something I'd never done before. And these weren't major changes. These were little tweaks. And the important message, I think, is that it gave me specifically the confidence to tinker. When I say tinker, just changing your rates. I don't know if I'm typical or not, actually, so excuse me, but I need different ratios of insulin at different times of the day. So if I eat in the morning and have exactly the same food in the evening, the amount of insulin I need for that meal is different. But the course teaches you how to attack that, how to program your pump correctly, how to deal with it, and most importantly, it gives you the mental process how to go backwards. So if you get it wrong, it's not the end of the world. These things happen, and you can go back, reset, and start again. And by doing that and constantly addressing it, I'm pleased to say it's the first time I've seen Kelly since November last year. I'm still over 70% of the time in range. My HbA1c is not quite into the 8s, but it's lower than the 11s that it was when I was on the course, and it was constantly coming down. It still is. And my deviation is much improved, hanging around the 2%, which is, as I'm sure I don't need to tell this particular audience, the time in range, the standard deviation, they're the things that we're looking at, really. If we don't have massive changes and we're managing to keep in range over 70% of the time, generally speaking, our diabetes nurses are going to give us a pat on the back and send us on our way, preferably with a bag of wine gums, but they're yet to adopt that as a policy. So, yeah, the final part of it, the most important part, I think, for me, was the parts of the course that you don't use regularly. I'm very fortunate in that I'm very rarely ill. But it gives you these reminders that you do have online resources, you do have your course books, you do have everything, how to cope with sick day rules, which is important for a great number of people, and understanding the differences in the types of insulin delivery, your split way, your split dose, your multi-wave, everything else. It's just the reminders, the bits and pieces you don't use often, are brought back to the forefront of your mind, and therefore you can attack with confidence. And I think that's the underlying message here. It gives you the confidence to actively manage your diabetes better, and hopefully reduce the burden on your good selves. So yeah, that's pretty much it. I mean, I would happily be an advocate and poster boy for the Daphne course. It's the benefit is untold, or at least it was in my case. And getting to know the people on the course with me at the time, I would say that everybody on that course would say exactly the same thing. So yeah, that's pretty much it.
Tony, thank you so much. That's really thought-provoking, and I think a great example of something, really an effective intervention. Just a quick question for me before we'll just bring Lindsay and Kelly in. Apart from the wine guns, is there anything that we could have done differently to support you? Anything else that you can think of that would have been helpful?
As far as the course goes, not really. I mean, the course delivery, I was a little bit sceptical, if I'm honest. The previous Daphne I'd done was round a table in a room over the course of a week. This was a weekly meeting, pretty much in the same format as this. And I think that was born out of the pandemic and everything else. But actually, it fitted in. It was less impact on my day. And I don't mean to say it was an impact. I just mean to say that I got in, I went on Zooms, and I could be back working 5 minutes after the course had finished. I didn't have to commute. I didn't have to travel. On the wider issue, I was pleased to see in the news recently that the closed loop technology is becoming or going through a stage further through the process of being approved for everybody, because that is a financial nightmare for people who want to do it. I've been self-funding closed loop for 2.5, 3 years now. It's a lot of money, but ironically, the reason I don't now qualify for closed loop is because my control is so good. My control is only so good because of the closed loop. So I'm not going to take myself off closed loop to make my control go bad so I can get the funding to get the closed loop. But at the same time, I think that cases need to be looked at on a more cellular level, because without a doubt, closed loop has changed my life. It has improved it in a way that people without diabetes are not going to comprehend. And that, I appreciate it's a financial burden on the NHS, and I get that, and I know that resources are low, but there are a lot of people who are not as fortunate as I am that I can put that money aside and pay for it. And ultimately, I think people that can benefit from it, and as Kelly just pointed out, it is a type 1 thing. I get that. But people that can benefit from it long term will actually reduce the burden on the NHS. The health implications are not going to affect you so much in the long term if people can benefit from that technology. But that's just my 2 pence worth. I appreciate that these things take time, but I don't think the wider body of people fully appreciate what an impact and what a change that can have on people.
Tony, thank you so much. Are you comfortable to take a few more questions where time permits, if that's okay with you? There might be other things that colleagues want to ask, but before I do invite that, Lindsay, do you want to say anything, add anything to that, or Kelly for that matter? And then just invite. So we do need to leave a little bit of time, I think, for board colleagues to ask any other questions, but if you do want to come in, Lindsay, very happy for you to do that.
Okay. Kelly, do you want to go first, please?
Yeah, thank you, and thank you so much, Tony. I'm almost tearing up here. I don't think I could have put the course across as well as you just did, really, and thank you so much. I think what we often get, and I think as Tony alluded to, is patients are often very apprehensive about attending a Daphne course. They often feel like they're going to be told off or told what to do, or and I think Tony's put it really nicely as to how the course runs, really. yes, I think it's put that across really well. I think going forward, I think what we've kind of learned from this is that patient feedback is really strong when it comes to promoting the courses and things that we deliver, particularly around diabetes or any long-term health condition, really, where we do have an input and we help patients to manage, but they're actually managing it 99% of the time. So they need the tools to be able to do that. And I think to help promote our course and get more people on our courses like Daphne, and we do lots of other different courses as well for other patients with different types of diabetes. I think using the patient story would be helpful, and myself and Lindsay were talking about maybe doing a patient leaflet that we can help to promote the course with the patients story of their journey on that leaflet. I think would really help. So that's definitely something we'll look at doing. And actually going forward and thinking about the challenges on our service within diabetes, as again Tony alluded to, so Tony has an insulin pump. Not every patient with type 1 diabetes meets criteria for that pump, but that may well change after the technology appraisal comes through at some point this year. And I think that's going to be the challenge for our service. We've always risen to the challenges to meet these sort of targets and make sure that patients are getting the technology that they deserve and meet the criteria for. But going forward, we're going to have a lot more people meet the criteria for pumps and all the different glucose sensors, and we want to make sure that they're able to get that. That's going to take a lot of work and resources from our team, and we just hope that we are supported in making sure we've got the right resources to deliver that to patients for future, really.
Thank you very much, Kelly. That's I think added a bit more to the story that Tony's given, which is really helpful. Just to mention, I think, Richard, haven't we got a diabetes event coming up as a future governor members event for the public?
We have indeed, yes, it's coming up in March.
So we might want to connect. I don't know who's involved in that, but Richard, we might want to just make sure that we have the opportunity to promote the course if we've not already included that, depending on who's leading that. But yes, it's an event on diabetes for members of the public and members of the trust and governors. So it's a really good opportunity to highlight any interventions really that we think people would be interested in. Okay. Lindsay, I'm conscious that people do desperate to come in. So is it all right if I bring a few people in and then loop back round to you?
Sure.
So firstly, Angela.
Thanks, Krishni. Just want to say thank you, Tony, for sharing that story. It is really powerful to hear about it. My daughter's got type 1 diabetes, so I absolutely understand what you've described. And what I would say is that even though it is a relatively common condition, diabetes type 1 or type 2, I don't think many people realise the impact on people's lives and the way in which you have to manage and, become that expert yourself in managing your condition. And I think there's still more to be done in raising the profile of the impact on people's lives and how the technology does make a difference. My daughter's got a pump and it's been a game changer in that sense. So I know and understand it. And she's been, obviously received support from the team and the course. So I know what you've described as well. But I think we've got to do more to raise it. I'm really pleased we're doing an event on diabetes because I think that's very important that people do understand it more. But I think it's another example of where co-production is really key, because whilst professionals can help, you as the user are the expert, and actually working together is when you get the sweet spot really in terms of getting what you need. And I think we need to think more about, are we doing enough to get more of that peer working in the organisation? So that was the thought that was left with me, but really helpful story. Thank you very much for sharing.
Thank you, Angela. Richard Wheeler.
Yeah, hi, I'm Richard Wheeler. I'm the Finance Director with the Trust. Thanks, Tony, for sharing the story. I had a question that might be more for Lindsay and Kelly, really, thinking about this from a health inequalities perspective, and how I don't know how people get referred onto the course, or how we try and reach some of those hard to reach groups.
So generally we get referrals from lots of different avenues, really. So the consultants will refer if they see patients in clinic that haven't done the course or that they think would benefit. We get a lot of referrals from practice nurses. So yeah, it's really kind of promoting the course with them, really. And we thought if we were able to produce a more bespoke leaflet, we did have one years ago, but it probably needs to be updated, then we can share that, because we go out to all the practices in Northamptonshire as diabetes nurses, and we do joint clinics with those practice nurses. So that's a really good way of getting, a bit more promotion around the course. But yeah, I'm sure there are other ways as well, because yeah, there are some people who have never done the Daphne course and would really benefit from it, I think. And I think the other great thing is that although the pandemic was awful, it did bring some positives, that we are able to offer the course remotely and face to face. So that sort of reaches more inroads, really.
Yeah, thank you, Kelly. Julia?
Thank you, Chrissy. Hi, Tony. I'm Julia Curtis, one of the non-exec directors. Just to say thank you. There's lots of comments in the chat. I'm not sure if you can see those, but everybody's saying thank you very much, really thought-provoking. For me, what's really come across from you is about the importance of prevention and investing in some of these services to prevent problems deteriorating for the future, really. And two things. One is that our integrated care system, one of the main priorities is around investing in preventative services. So that's really good, I think, for the future. But what came across from you was that to give you the confidence, you said to tinker and to go back and try again when things go wrong. I didn't want to lose that, because that's priceless, isn't it? I can feel
absolutely.
it. Yeah, and often when there's competition with services that are sort of seen as, helping life-threatening conditions, etc., the importance of investing in your type of support has really come across loud and clear. So thank you very much, and good luck for the future, because it sounds as though we've given you some confidence to take forward. Thank you.
Oh, pleasure, and thank you. Yeah.
Thanks, Julia. Dave Williams?
Lovely, thank you, Christian. Thanks, Tony. I'm David Williams, Director of Strategy and Partnerships. Kelly, Lindsay, listening to everything and building on Richard's point about inequalities, I wanted to just encourage you. You've talked about patient leaflets a couple of times, but in terms of reaching lots of different communities and lots of different age profiles, I think it would be worth having a conversation with our comms team about actually social media, videos, real different ways of reaching out to people. I'm probably a generation that does read a leaflet when it comes through my door, but I'm right at the very bottom of people who probably do. And so I think thinking about how can we reach everybody who will benefit from Daphne through lots of different media would be something we should keep exploring.
Yeah, I think you're absolutely right, but I think that we are a relatively small team, and I think it's getting the word out to everybody else. I mean, diabetes, it's across secondary care, primary care, community care. It's everywhere, isn't it? So I think, helping professionals understand those implications of diabetes and understand what the courses are about. They're the ones that will be ultimately doing the promotion, aren't they? They're the ones that are actually going to be offering, the practice nurses, the GPs, they're the ones that are going to be offering these courses. So they need to have that understanding so that they can appropriately do the sales and the encouragement and answer the questions about the course.
Our comms team, our comms team, you're part of Team NHFT. There's a bigger wraparound service that can support you. You don't have to do it alone. And actually, they can connect you with messages that can go to the Integrated Care Board, to GP practice development sessions, ways of feeding things in. They can help us create the tools. Then everything can be shared. So it's just thinking all of those different ways we can help reach people.
we do find as a team it can be really tricky to have a voice within primary care and gain access to their PLT sessions and things. We were talking about that just recently, about the whole diabetes pathway and how we get that representation from diabetes and high risk foot through to the work the MDT do and retinal screening and so on. So it would be really good if we could have support having that avenue in.
Thank you, Lindsay, and thanks for the point, David. Robin?
Hi, pleasure to speak for the first time in one of these meetings. Thank you, Tony, so much for that. Like Angela, I'm also the parent of a type 1 who's benefited from the Daphne course, and I can also endorse the game-changing nature of the quality of those courses in terms of the psychological aspects of motivating people to take control of their diabetes. So many other points, Angela made some of them. The partnership thing that you illustrated so well, Tony, that it is co-production in healthcare between healthcare professionals and patients, written absolutely clearly. But the last point was the health inequalities one, which is that you were able to support yourself financially to do the closed loop system for a while. My own son was also self-financing part of his own care because he wasn't in the UK. So it is the risk that the take up of the most advantageous approaches for diabetes is very often with those who are the most able financially to do so. And so we do have to think about the health inequalities and financial aspects of this in trying to argue the case for access to those kind of technologies.
Thank you, Robin. I think that's a really important point. I mean, I come from a family, fortunate enough not to have diabetes myself, but I do have a family background of diabetes in my, and it's, I believe, more prevalent. Am I right in thinking more prevalent in certainly South Asian communities? So that point about reaching places, I think communities and people, perhaps from other protected characteristics or just be more vulnerable or more deprived communities is really important. And I wonder how much, I'll bring Angela in on this, but I think diabetes is I would imagine, a priority for the integrated care system because I think it's such an important area for prevention. So Angela, do you want to add anything to that?
Yes, we're just thinking, I mean, obviously, even just in the discussion we've had this morning, we've recognised this touches every sector, every part of the population, and it is growing. And technology is growing at the same time as well, and health inequalities are also growing. So I do wonder whether Julie, Linda, in terms of the clinical leads discussion, whether we could advocate for a discussion about diabetes through the ICB, just to take stock of what is happening. Not because people are not doing great things, they are. We've just heard about them this morning, but also just look at it collectively. I just wonder if that would be something we could push for through that clinical group.
Itai, do you want to come in on that?
Yes, I certainly work on that suggestion, Angela, and I think particularly with the collaboratives and kind of population health management approaches, there tend to be some overlaps between some of these kind of metabolic conditions and even mental health. And there's scope for us to address health inequalities, as a two-pronged approach. So this is certainly something that we'll take forward.
Great, thank you, Itai. Lindsay, I'm conscious there was, I know you responded to one of the suggestions, but was there anything else you wanted to add to anything we've heard today?
Yeah, just on that last point, there is a work with the ICB going on in relation to diabetes transformation. We've not had a good look at diabetes since the MDT was formed, probably 2010, 2012. That's the current pathway for diabetes care hasn't really been looked at, and the service specifications haven't been looked at. You're looking at 10, 12 years now since anything has changed. And in that time, when the pathway was originally developed, we had 28,000 people with diabetes in North Hants. According to the Diabetic Retinal Screening Register, we now have 50,000 people with diabetes in North Hants. Some of that's explained by the increase in diagnosis of type 2 diabetes. You'll probably remember many years ago the missing millions, and you know, we weren't diagnosing, so of course now we are diagnosing. But you're also seeing the increase because we've got an aging population, so treatment has improved so much for people with diabetes that they're no longer dying of cardiovascular disease and renal failure and so on, and they're living well into older age, which of course puts the pressure on community nursing services, palliative care, and so on. So it does go across the whole system. You are seeing, you know, people with diabetes adversely affected by dementia and cancer now, whereas actually people didn't live long enough to actually develop those conditions. So it is a very changing landscape, and I would certainly, because I was involved in the MDT development all those years ago, and I've been around in diabetes for a long time, I know that the budget hasn't really changed significantly from what it was in 2010, 2012 to what it is now. So there hasn't really been that increase in funding. As you've heard from Tony and Kelly, a massive increase in technology, huge increase in technology, and you get the guidance and the information down saying you need to adopt these are the people that should be suitable, you need to put in place actions to ensure people can access these technologies. But that I've never experienced that come with any funding for the staffing resource to support that. And often they are presented as ways of helping the health service and reducing the burden. As Tony said quite rightly, if someone can manage their diabetes very successfully, they are much less likely to have the long-term complications of diabetes. But actually, there's still the support along the way that's needed for those people. The technology is hugely complex and complicated. And I think we have been very proactive in fighting the corner for those technologies, and certainly as far as continuous blood glucose monitoring goes. And you might have heard about the Libra device, the flash blood glucose monitoring. There are other devices now, but we're in the top 5, I think, in England for having the most people with type 1 diabetes on that technology now, and that was because we were very proactive when it became available. But as I said, sorry, so you know, so what I'm saying, I think, is that actually there is talk in the ICB about a transformation of diabetes and moving forwards, but it's going to be a long time in the coming, isn't it? And there's lots to think about. One of the things I think we do need to think about is staff working in different ways. We have a real challenge recruiting staff and recruiting staff with the necessary skills. And we do, as Kelly alluded to, we provide a vast range of education for both patients and staff. But encouraging people to attend in the first place can be a real challenge. But invariably, when people attend for type 2 education or type 1 education, invariably the feedback is absolutely positive. But it's got to be the right time for people to attend as well. It's not always the Lindsay, right time for them.
I'm sorry to interrupt, but we are going to need to bring the item to close. We've heard a really fantastic insight into the course that you provide and the impact that it's had on Tony and the benefits of that. I do think the conversations and the issues that Lindsay's raised are important ones to follow up on. So Ty, if we can leave that for you and Julia and Linda, as Angela suggested, to sort of think about how we raise the profile of the conversation with the integrated care system, because that's really where we need to address, I think, this sort of collective view of how we look at the pathway, because that will cross, I'm sure, into other partners areas as well. So Tony, can I just thank you again for taking the time and making the effort to come and join us today. I think it's given us a really good insight into something that we all sort of think we know about, but it's so good to hear from you directly to understand more the impact on you, but also the benefits of the course. And I think the thing I've been struck by is it shows, we talk about self-care as something that's really important in and prevention, and here's an example of something that's happening now. It's not something in the future, but it's happening now that's helping service users and patients, and that obvious opportunity around technology as well is the other area that we touched on, and we've not really had time to explore, but I think it does highlight that this is an area where that benefit is potentially there. So thank you so much, Tony. Thank you, Lindsay. Thank you, Kelly. Brilliant work. Great story to bring to the board, and I really appreciate you joining us today. All right, thank you.
Thank you.
I'm going to duck out, everybody, because I think you're now going to talk about things I will have no comprehension of. So thank you. Thanks for the opportunity as well, and thank you all for listening. I also have a habit of droning on a little bit, so I apologise for that, but I will wish you well and have a nice rest of the meeting. Thank you very much.
Pleasure to have you, Tony. Thank you very much. And Lindsay and Kelly. Thank you.
Krishna, is it okay if I listen in?
Of course, yes.
Yeah,
please
marvellous.
do.
Thank you very much.
I'm going to leave you, sorry.
Yeah,
See
no
you later.
problem.
Thank you very
Kelly.
much.
Thank you.
Bye.
Okay, so we're going to move on to our item 8 on the agenda, which is the organisational risk register, and it's paper D. So over to you, Chris.
Thank you, Krishna. Paper is to give assurance to the board on the management of risk, been reviewed by the Strategic Exec Board, and changes are included. Key changes are on B8, the failure to make best use of resources due to inflation and COVID pressures. Richard has increased the score here as Finance Director to 16. On the capital allowance not being sufficient, because in effect we've got real operational pressures and inflation, we actually won't be able to progress those, so that won't be impacting on the allocation. And again, the score's been reduced to 9. The excess demand that's been experienced has led Jean as Chief Operating Officer to increase the risk there, and you'll see that the one of the committee meetings was stood down because of the critical incident and the pressures, so that's only too real that that's increased. The risk on closed culture has been included. We have done a review which has given positive assurance, particularly on the quality and safety review through mental health. There was a challenge around this. Did we feel we did need to put this risk in? But Seb had quite a long discussion about this and reviewed it, feeling that it's very much an emergent area, and some trusts like ourselves, we've been in very positive places, have actually experienced feedback on closed cultures. And we really felt that it was an issue because this is so new in what we're doing. It's a bit, I think it's Donald Rumsfeld, I'm never sure which Secretary of State of the US is, you know, we don't know what we don't know. And I think we feel that that is a challenge. So as an executive team, and we know we had the discussion with Neds, we felt it is appropriate to keep it, probably for a period of 6 months at least, and keep it under a close review. The ICB have received their BAF, and we've included the dependencies of the ORR within that. And again, in terms of the corporate risk register, the EMB have identified the linkages to the ORR. On risk overall, the exec have been discussing where we are and have identified we want to do quite a full, if we can get a whole day to look at risk and really go further in depth. And whilst we feel, as we've discussed here, we're in a good place, we want to see how that can be improved and developed. And again, we've got a consideration of the risks that are below appetite, which can be considered in January at the Joint Committee, but we'll come back, and that will give us a chance as an exec to look at that in more detail. So just to assure the board that more work is going on to test the risks and where we are. So really the decision for the board is the board's happy to confirm assurance from the ORR.
Thank you, Chris. Angela?
Yeah, I just wanted to frame the closed culture piece, building on what Chris has said. I think it's really important to say that we've always monitored the closed cultures because clearly there is a CQC guidance to do so. But what has transpired through a lot of the media coverage is that clearly places had got assurance and they had closed cultures. So what I think this will do was allow us to review all of our measures and monitoring, which we have, to check if there's anything else further that we think would benefit from. And obviously, James, as the Director of Patient Safety, is leading that for us. Thanks, Krishna.
Thank you, Angela. Melanie?
Hi, yes, two quickish questions. One was around the system risk considerations, and really good to get visibility of those and the linkage with our trust risks. I assume, but I just wanted to check, therefore, that any action plans and mitigations underpinning the system risk will now be translated and written into our risk templates for the trust risk to recognise any system activity that will bring benefit and mitigation for us. And the second question really was just an update, and sorry, because this might have been covered in one of the committees, but with the absence of Fiona, I just wondered if there was an update on our progression of developing the risk template and improving it, as we've discussed a number of times over a number of months, into something that is more workable and better for us to understand the risk through. And I wondered if anyone could give me an update on where we are with that work.
Thank you, Melanie. So should we just pick up the ICB question first? And actually, just to add to that, Judith's added, I was wondering whether you could expand a little on how our risk management links with the ICB ORR. So I think there's a bit of, okay, we've done that, but what are we've done that piece of analysis, but what next? Really with that, and how we're going to use that. So I don't know whether Chris or Angela, I can see you wanted to come back in, whether you wanted to comment on that.
Yes, I mean, I'm sure Chris and Richard will talk about our internal piece, but I think it's important to frame that the ICB is still very much developing. So remember, it's came into operation in July. It is getting to grips, I think it's fair to say, in terms of how it looks at risk. And we've only just started to see some of that risk material coming through the ICB. They have looked and I think helpfully adopted some of the ways that we're working in terms of how they use and report on risk. And certainly through the Mental Health Collaborative, they took the work that we were doing to quantify risk into their thinking. But I think it'll be an area where we have to keep coming back to understand how it fits with the developmental path, Krishni. It's probably something perhaps to look at as a board development in due course. Are our risks aligned? Are we clear? Are we sure that they are dovetailing as we want, and people understand the risks and where they sit? But I think it's important to recognise that developmental nature of the ICB. Thank you.
I think that's helpful, Angela, and Richard Smith and I can, I think, pick up maybe building that in, because I think that's a really good way of sort of exploring, having that conversation, and because it's a bit of a two-way street, isn't it? Ultimately, you know, we need to then have conversations with the ICB about where we, you know, where we feel that there might be things that we need to raise to their attention, which are shared risks, if you like. So that's a good way, I think, of taking that conversation forward. Thank you. Melanie, on your other point, I understood that we were looking at the reporting template. I wasn't clear we were looking at the risk template, but Richard, do you want to comment on that?
Yes,
sorry,
I
did mean, sorry, just a clarification. I did mean the reporting template, the single slide template that we use on every risk. Yes.
Okay.
Yes. So on that, we do have a work plan in place, as you've alluded to, Melanie, that largely Fiona initiated, and we're continuing to progress that work. So as part of the conversation we're having with the exec at the workshop in February, it should become clear what the timeframes are around correcting that. You're absolutely right. Refreshing that report template is part of that plan. So we should have some more information emerging following that exec workshop in February. And just to also confirm that, yes, we are, bearing in mind the evolutionary nature, as Angela's alluded to with the system risk register, we are nevertheless monitoring the action plans and so forth. So we've got that appropriate read across to NHFT's action plan. And I'm certainly meeting regularly with system governance colleagues to have a dialogue and a conversation about that as well. So we can certainly expect, I think, that to strengthen over the coming months as that process comes embedded within the system. Thank you.
Thanks, Richard. Scott?
Yeah, thanks, Krishni. I was going to raise an ICB question as well, but I think Melanie and Judith's comments and Angela's response, I think I've covered that. I think just a couple of quick pieces from me. So just to emphasise the point that Chris made earlier on, we'd taken a conscious decision in Performance Committee this month to wrap some of our scrutiny of the organisational risk register into the joint committee session. and just as a complete peculiarity of timing between the end of performance committee and the big scheduled beginning of the joint committee, we'd had to declare the system critical incident, and unfortunately the joint committee didn't go ahead. So what I wanted to try and emphasise is that obviously the week before, UNS will have had the opportunity to scrutinise the organisational risk register. It's not for assurance to board. It's not that it hasn't had non-exec oversight. It's just obviously in the circumstances it didn't happen around this. So just wanted to make that clear. And then secondly, wanted to follow up on the comments around, whilst I understand the increase to the risk rating for B8, it's quite concerning to see that, and obviously, particularly with the risk of the potential impact on our SOF rating. I just wondered whether either Chris or Richard Wheeler wanted to comment on that any further.
I think I'd probably be Richard would need to come in, Scott, on that one.
Yeah, thank you. That's helpful, Scott, because that's what I was going to come in to. So as you say, we've raised the risk around B8, particularly the resourcing pressures. So we're seeing a lot of pressure from the capacity demand, pressures on our operational teams, inflationary pressures and workforce pressures that are manifest into pushing the trust into a deficit position, which I'll talk a bit more about when we talk about the integrated performance report. I would like to clarify that we are on track with our value efficiency program, and also from a kind of workforce productivity point of view, we're seeing something like a 67% increase in mental health activity compared to March 2019. So in terms of, while there has been a growth in funded workforce in mental health, our actual activity and therefore productivity has increased way above that. So it's really the resourcing pressure driven by inflation, workforce, and the demand on our services that is causing the financial risk that we're overspending against currently.
Okay, thank you, Richard, and no doubt we'll come back to that later. Is that okay, Scott? Because obviously that'll be part of the discussion for later anyway. All right.
Absolutely, I agree. We'll come back to it later, Krishni, and I think probably rather than try and do it twice, we'll defer the rest till later. So thank you.
Yeah, thank you. Jean?
Thank you. Just wanted to update the board that risk B4 we are currently looking at. We've identified a few issues that have come to light over the last week regarding our data. So as an exec team, we've been discussing those, and we will be reviewing that risk, probably with the likelihood of increasing the risk associated with our data, quality of our data. But we will come back to you when we know more. Thank you.
Okay, that's the ensuring we have consistent, timely and accurate data to improve patient care. That one, yeah. Okay, yes, thank you. Thank you, Jean. Just on the closed cultures one, I think it's really sensible to maintain that. I know we've had the we've had the review, but the emerging picture, and in fact, I think I'm right in saying there's been a national commissioning of a national review around this now. So the emerging concerns around mental health services nationally, I think, suggests we shouldn't be. I think we need to be wise to the possibility that or certainly be focused on this consistently, and in that sense, I think keeping it on the risk register is a sensible thing. We did brief the governors. I just wanted to mention in the public Council of Governors meeting, Julia very helpfully talked through where we were. So I think I'm sure the governors would welcome the decision to maintain it on the register, because I think it's an ongoing concern for colleagues. And in fact, Julia's put her hand up, so I'll just bring her in case she wants to add anything to that.
Thanks, Krishni. Yes, just to say, actually, you've taken, I think everybody's taken 3 or 4 of the points that we were going to bring out, or we will still bring out a little bit later on in the feedback from Quality and Safety Committee, because we did have a really good discussion. But I will cover it a little bit later on, but just absolutely reiterate everything you said there. Very pleased to see it as a risk, and it will be monitored, we know, through different fora, which gives us the opportunity to really look in detail and to reiterate that at that discussion at Quality and Safety Committee in December, the last comments we made were all about, this is not a one-off, this is absolutely about ongoing work and the importance of reviewing all that information and triangulating it wherever we can. So I'll come back to it a little bit later on, but thank you, just to endorse everything you just said. Thanks.
Thank you, Julia. Okay, Jean, was there anything you wanted to add in relation to wider system pressures, etc., linked to this?
Yeah, I think it's just important just to give the board an update, Christian, if that's okay.
Yeah.
So it's been really challenging since the last board meeting, and what resulted in both of the acute trust declaring a critical incident. We then, as an NHFT organisation, declared a critical incident on the 5th of January. That continued to the 9th of January. Now, there is lots of reasons why we were led to that position, some of which was to do with the additional activity that we changed and implemented because of the position in both acutes, such as boarding patients on our community inpatient units, but also the internal pressures that we had ourselves, particularly in terms of mental health services and our community physical health services. Those risks still remain and the pressure still remains, particularly with mental health. We are running at 100% plus occupancy across all of our wards at the moment, and that is, of course, having significant pressure on our services. In addition, we are holding a number of patients in the community with our community mental health staff who are awaiting a mental health bed. So again, it's just more pressure that we are continuing to manage. And I think it's also worth mentioning about the industrial action that has taken place over that period as well. So there's been a number of days, both from an RCN ambulance strike perspective, but also people will be aware of the future strikes that are planned that's been publicised in the media. We've been managing those through the SPOC and also through a internal industrial action meeting that Chris Oakes chairs. So just to give assurance that we are, we've got a number of belt and braces approach to ensure that our services continue to run. I think Anne and I were sharing some concerns we had relating to the teachers' planned strikes that are also coming up and the impact that's going to have on our staff in numbers. So just to make the board aware of that as well. Thank you, Krishni.
Thank you, Jean. So yeah, challenging. It's obviously been a challenging period, and I think we clearly all recognise that, and recognise the efforts of staff and all the colleagues around the room in continuing to maintain services safely and supportively. Just going back to paper D, I'm conscious that Chris asked us obviously to receive that report and receive the assurance around the process. Clearly there are some significant risks that we have discussed and are mindful of, but as I said, I think we do support the inclusion of the closed cultures risk for the reasons we've discussed. So thank you very much. I'm conscious that we've already heard the joint committee was not able to run, but on paper E, was there anything else to add? Was it Scott or Julia? It was just for receiving, Julia?
Yeah, just for receiving. The information's there, and it was that day, which was very unfortunate, but obviously needed to make sure that our exec colleagues were able to help manage safely the critical incident. So it's there. Thank you.
Okay. Thank you. That concludes our section on risk, and there are obviously some elements of that, particularly in relation to the financial risk that we touched on that we will come back to later. So we move on then to the strategy section. We start with the environmental analysis, which is really our opportunity for any comments about the sort of general environment that we haven't included in papers. So, Angela, anything that you wanted to bring to our attention?
I don't think there's anything further that we're not going to cover, Christy. Thank you.
Okay, thank you very much. So I just draw the board's attention to my report, which is paper F. I've already taken the opportunity to welcome Robin. At the time, I wasn't able to formally sort of officially name him in the report, but you can see that we were expecting and hoping that we would be able to conclude the process to bring Robin on board for this board meeting. So I was really delighted that he was able to join us. The key point I really just wanted to make is that we also, in the process that involved the appointment of Robin, we were also successful in identifying 2 associate NED candidates. We're in the process, so we have candidates that the council has approved, but we're in the process of working through the onboarding of that and a staggered arrangement around that, which we're expecting to take place over the coming months. And just to really confirm, you know, as I said earlier, you know, council and our governors in our nominations remuneration committee were very supportive of the idea of bringing on associate NED. Just to be really clear, we've taken a slightly different approach to perhaps trusts generally in doing this, because we in effect were in the process that we went through, we looked for people who were NED ready, if you like. So it wasn't a developmental role, but people who we would feel could take up a NED role. So it was really to help us with succession planning, and the opportunity then exists for us to for those associate NEDs to slot into a vacancy for a formal voting NED role when those opportunities arise. So it really does give us a very clear pipeline. Obviously, if the requirement was for a very specific set of skills that associate didn't have, then, for example, clinical skills, that would be a different situation. But for the generic requirements we have around non-executives, that felt like a really good solution. So thank you again to our governors and indeed board stakeholder session that was involved in coming to that conclusion, and we look forward to welcoming other colleagues onto the board in an associate capacity. I think we're talking about March and April at the moment, aren't we, Richard? So we'll just go through that process. And so that's it really from me. Any questions before I hand over to Angela for her report? Okay, Angela?
Thanks, Krishni. And as we've already said this morning, Jean's described some of the challenges and we've heard them, but enormous thanks from me on behalf of everybody to all of our staff, you know, volunteers, governors, our staff. Everybody's been amazing, because despite the challenges that have been described, you know, safety first has been the focus, and, you know, clearly the critical incident was also a safety first opportunity, and I couldn't be more proud of people. I really couldn't. So important to say that. A couple of other things just to highlight. You'll see that we've referenced the planning information for 23-24. That is clearly a big focus at this time. That's being led through Dave Mayer, supported by colleagues, but that is going to be really significant for us as an organisation. We're pleased to see that the mental health investment standard is still a feature, giving it some sort of sense of difference in there, but we know equally challenging finances will mean that we'll have to have some challenging discussions, I think, on a local basis, but important nevertheless that that's been secured. You will also see the reference to the CQC and their regulation and what their plans are, and I'm pleased to say that we've got a joint board session coming up next week with Leicestershire Partnership Trust in our group, and we've got an opportunity there to hear from the CQC with Craig Howarth joining us. So I think that will be a good opportunity if anybody's got any questions to hear from him directly, because there's a lot of change ahead, and it's really important that we stay close to that. In addition to that, I would just want to share that we had our quality regulatory review as a system not long ago, and I'm pleased to say that the regional director described our community transformation in mental health as exemplary, which I think is important to share. And in addition to that, the work that's being led through Julie as Improvement Director at St Andrews via the East Midlands Alliance as nationally leading. And I think those are really important. There's things that we know I'll go beyond the organisation, and clearly good to hear that feedback. Clearly challenge around finances for system, which we'll need to work through, and that is not peculiar to Northamptonshire, but it is going to be a challenging period in 23-24. And then the other thing, just to mention two other things, is clearly we had a Prime Minister visit this week, and I want to say thank you to everybody who mobilised to support that visit. These visits come on us quickly, and it was really great that we were chosen in the first place, because he could have gone anywhere to make the announcement that he did. He wanted to do it from our organisation, which is a credit to everybody working in it. And I'm pleased to say it was a very positive visit, and there was good coverage and a lot of support from everybody to make that happen. And then finally, just to say, I attended one of the modules in Diversity and Healthcare Partners yesterday, and just to really just commend that range of opportunities to board members. These are really fantastic opportunities to go and mixed across the country, but also to hear from some very, very, very powerful speakers. So again, we can share the materials as I get those through, but look out for those opportunities that drop into your inbox, because it really was one of the best things that I'd attended actually for some time. So that's all I'm going to say for now. Thanks, Krishni.
Thank you, Angela. Any questions for Angela regarding anything in her report or anything she's mentioned? The only thing that came to my mind is that I think there's been an announcement about a patient and carer race equality framework, which is specific to mental health. I wasn't clear in my mind what the timescales were for that, but it sounded like quite a positive development in the sense of kind of recognising that some of the challenges, higher rates of detention and those sorts of things. Is there anything you can say on that, Angela?
Yes, there's lots of work underway. I think it's fair to say, and we're fully involved with it. And we talked even about it in the Together Against Racism work this week, because obviously it's a component there as well. So there's a lot of work going on that, Krishni, already on the front foot, I think it's fair to say on that. The only other thing I would say, though, and it's probably in reference to in my report about monitoring the Mental Health Act, clearly people would have seen the CQC report and some of the findings, etc., and some of the messaging. And I do wonder whether it would be useful for us as a board just to ask the committee that works on behalf of us just to have a look at that report and to understand our relativity to it and to give assurance to the board. I think that would be worth doing, Krishni, over and above just reading the report. Thank you.
Okay, thank you, Angela. Anne, did you want to comment at all?
I was just going to add in that the PCREF piece nationally, that we're going to have a presentation and have already had an initial presentation at our Equalities Enabler and our Moving Ahead project. So we really are keeping close to it within not just the collaborative, but within NHFT. So it's quite exciting work.
Great, thanks, Anne. That's great. Okay, well, thank you, Angela, for the report, which we've noted and received and obviously commented on. So we now move on to our people section, and we have the Trust's annual equality. Yes, Chris.
Yeah, just to say that PCREF is something that we are going to look at throughout Together Against Racism as something that we can do some work in the group on, because it is something we can collaborate, and as Anne's talking about the collaborative and in mental health, so it is something that we're aware of and picking up. Yeah,
thanks, Chris. Well, back to you anyway on the people item, which is the annual equality information report.
Right, so thank you again. The report covers our specific duties in relation to the Equality Act around sharing equality information, and also our progress on our equality objectives. You'll see the front sheet lists out the key requirements in relation to the equality duty, and particularly in relation to the protected characteristics and the information around those areas. We certainly, in terms of some highlights within it, I'll just draw those out. is that we've got a lot more detailed information on patient information. Historically, this has been quite staff focused, but now we are really developing the patient information. We've increased our representation of colleagues from ethnic minorities across the trust, and interestingly, they are tending to be in the middle and higher grades rather than the lower grades. We've also undertaken some benchmarking on the LGBTQ, which is the Stonewall Workplace Equality Index. So again, work coming forward on that. Again, it's sort of feeding from our Together Against Racism across the group. Directors, you'll all be aware, we all have pledges, and we've linked with our reach networks, and we are looking now to evaluate how they've been used. That's the next step we'll be taking. We've implemented the inclusive recruitment ambassadors. So this is people with training who are going to be on all of our panels, certainly for 8A and above, and look how we can expand that. And we've implemented a process to say no to racist patients who are racist towards our staff, a 6-step process, which again, we've also shared across our group, so really positive. So just some highlights there that out of the report, which you'd have had a chance to read, and just ask the board to approve the report today, really.
Thank you, Chris. Yeah, just a reminder, we're required, I think, to publish it, aren't we? I think the norm is that we're required to publish it by the end of the month. So
End of the month, that's it.
yeah, so it does require approval before publication. So there may be things we want to sort of pick up on that we want, obviously, focus on, but that's the reason why the report is here. Couple of comments then from people. Saqib.
Hi, Chris. Great report. Got some great insight. Just a couple of questions. You mentioned about the BAME colleagues doing well in the higher grades. I wanted to know whether we have the information. I think we have it in one of the other reports that we do of what it would look like if you stripped out clinical colleagues, because often there's a higher proportion of BAME colleagues in the clinical grades, and the clinical grades are often, I mean, obviously they're spread, but you know, there may be some reason that why it's looking as if they're higher. I'm just wondering whether it'd also be true in non-clinical grades. And then the second question, sorry?
Don't carry on.
Yeah, and the second question, I noticed on the patient profile, only 1% were Muslim. And if you then look across to Pakistani, which is only a rough guide, but Pakistani and Bangladeshi, which are largely Muslim background, is also 1%. But the population of Northampton town, at least, I don't know for the villages, but I would say is probably higher than 1%. So whether that reveals the fact that we probably aren't we're not reaching some of those demographics as best as we could do, or they're not asking for our services in the same ratio to the actual number of residents that live in Northamptonshire.
Oh, I think well, that's a useful point. I think that's the point of bringing it. We can take that back. As I say, we are getting much better information that can prompt some of those areas to be looked at. We are building that equality work across patients, and the PCREF will do that as well. So thank you for that. On the previous point, I think when you say clinical, you mean doctors, do you?
Yeah, because the vast
doctors
majority,
and nurses, I guess. Doctors, nurses, and apparently, you know, other professions. If you strip out, like, if you're looking at admin particularly, I guess.
But it's the vast proportion of our staff, though, are clinical, Saqib. So it's a bit of a, it would feel a bit of a sort of misnomer. I think if it was proportionately more doctors, I think that's a separate issue, but actually it's really important across the nursing grades, because that's where progression hasn't been evident in the past, and where we've made progress on that, that's important. But the proportion of corporate staff would be relatively small. So it probably wouldn't have I don't know what the percentage is. Chris would know better than me, but I think it's progression in in nursing roles, I think, is really an AHPs, and that sort of is really important, I would argue. Chris, do you want to add to that?
Yeah, the exact, but yeah, the corporate is a much smaller percentage, you know, sort of 10-20%. The bulk of our staff are all clinical staff. And obviously there is a challenge there with doctors, because historically we have had higher representation of ethnic minorities in the doctors, which could be to skew it. But this actually does relate to what we'd call our agenda for change grades. So these are the core kind of nursing, AHP and admin staff as well. And we have a higher proportion, you know, we have those groups well represented in the middle and higher bands. In fact, interestingly, I think the report is counter to say the position in London, underrepresented, but we haven't got many staff from an ethnic background in our lower grades. So, you know, is that a positive across that group?
Thanks, Chris. Just one thing to add to Saki's point. I think probably for me that the sort of broader point on the ethnicity data is what a percentage is unknown. And in a sense, that feels like the thing we need to address, because actually then we will have an accurate view of the base of our patients and you know, and better quality data. So I think that's recognised anyway in the action, but there's something like, I think that's 35% or something like that was actually unknown. And so, you know, it's really getting to that level of granularity, which I think is important.
I think that's a very important point, Krishna, and that does need to be an area of focus. That's a bit like with our disabled staff and long-term conditions. One of our biggest issues is the reporting, getting people to be comfortable to report, because we know the difference between what we see in the figures on ESR, the staff system and the staff survey are quite different. So that is an area of focus moving forward.
Absolutely, thank you. Julia.
Thanks, Krishna. It builds on your question about the data. That's exactly the point I was going to make about the unknowns. But I suppose for me, it's about whether people have actually been asked and declined to give us the information, or whether they've just not asked, or whether our staff haven't felt comfortable asking. So I know it's a nuance, but actually it might help us. If lots of people are declining, then there might be genuine reasons for that. But actually, if we're not asking the question in the first place, then that's something different to address. So actually, I think you've probably covered my point, but also just to say thank you for a really readable, interesting report. That the graphics really help and make it easy to sort of understand. So thanks for that.
Thank you, Julia. Shall I bring Scott in and then just come back to you, Chris? Scott?
Thank you, Krishna. Chris, a couple of points. I've put some comment in the chat. There's a minor typo in the report. I'm looking at it in diligent, so it comes up as page 70 in my report. There's it's just some X's that are still in it, and I'm only mentioning that because you're asking us to sign it off, so just draw it to your attention. Okay. I'd also like to support the comments that have been made by others. I really enjoyed the report. I thought it was very, very digestible. Definitely brings all of the factors associated with it to life, and you know, I'd like to thank you and all of the other people that have been involved in pulling it together for that. I thought it was really good. Just one comment, Chris. I'd just be interested in your view. You know, I think a really positive step to hear what you were saying earlier on about how we would support staff who are subjected to, you know, aspects of racial or ethnically motivated abuse. You know, I think that's incredibly important. Just wondering why we would limit it to just that and not all of the protected characteristics. You know, so obviously you would expect me to ask the question because I'm the board sponsor for the LGBTQ network. But surely we would want to be supporting our staff regardless of, you know, unacceptable behaviour, if it was motivated by any of the sort of sources associated with protected characteristics.
Thank you, Scott. I can see Jean's put her hand up. So Jean, do you want to respond?
Yeah, thanks, Scott. I think it's a really important point. It's something that we're actually looking at as part of the staff safety and security group in terms of how we can assess impact on every single one of our protected staff with protected characteristics. There's a big piece of work that we're doing on that Chris's team are involved with that will absolutely triangulate and cross over with some of that work. So you're absolutely right, 100% agree that it's a big piece of work that we're hoping to come back to Q&S committee with updates on in the forthcoming months.
Yeah, and I think we...
Go on, Chris.
Yes, we're picking that up. I think the key point is it's in response to the challenges. So the big challenge initially was that we had people who were being racially abused, and they will find staff were finding they didn't have a way to deal with this or raise it. And it did take, well, Jean will bear out, it took a lot of work because it's to make sure it actually worked, and this 6-step process that we use about how people pick up. And now we've got that embedded, and we've got it embedded in a couple of areas, and the plan is to spread it across the trust. And then, as well as you're suggesting, we can pick up, you know, wider protected characteristics. But where we didn't have it, the positive is we've got it, and now we need to really embed and make sure that's a reality for everybody.
Thank you, Chris. I think there's just one other comment I wanted to make, and it's not relating to the report. So I think Scott is right. There are a few things that clearly just prior to publishing on the website, there are a few X's in there that I noticed.
Yeah.
I don't know whether that was just but I assume that those will be addressed.
There are a few bits still to rectify, but
just additions of some data, I think, and things like that that were outstanding. Just on a broader point, Chris, there's obviously a duty as well that's referenced in the purpose of the report, the covering report, around publishing gender pay gap information as well. And I'm assuming that's a separate report, but I wasn't sure when that would need to be done.
That needs to be published at the end of March, and we're gathering the data at the moment that we can then share with the board in due course.
And does that need to come to the board prior to publication?
Well, we need to make the publication. I think we have historically done that. I think that's a good idea. We can bring, and we'll be able to bring it to March and then go for the publication date.
Okay, wasn't sure whether it's on our forward plan, so hence just that question really. So that's
it's certainly on our plan, Krishni.
Okay, thank you. Okay, so we're happy to approve the publication of the report. Clearly, there's some things that Scott's highlighted that just need addressing beforehand. I think everybody said, you know, there's some really interesting insights in that, and obviously it's a pulling together of other reports that we've actually had fairly routinely, and then we'll obviously get a refresh of some of our res data post the staff survey results coming out, which I think come to board in March, if I'm right as well. So, or it could be May, can't remember. No doubt Chris or Richard will know. But clearly we'll have a refresh of the latest data, won't we, in the next few months once the latest staff survey has been published. So we'll see some more data around some of these areas. But really good to get a report that covers a broad range of things on the whole equality agenda and fulfil our duty to publish that on our website. So thank you very much, Chris, for that. I think we have the opportunity. We're a little bit ahead of time, so I'm wondering whether to maybe give ourselves a break now, if that's all right. So we now moving on to our quality section, and we first of all have our report from the Quality and Safety Committee. So over to Julia.
Thanks, Krishni. So everybody will be able to have read the report, but you'll see from this that the date coincided with the first day of industrial action last year, just before Christmas. So we agreed to condense the agenda and focus on the couple of areas that needed assurance and that were priority at the time. Just to give the board assurance, we did have the opportunity beforehand. We had all of the full suite of papers we would normally expect. We had the opportunity to ask authors of questions beforehand if we wanted, and on the day. So just to give you some assurance that we did actually go through these papers, even though it was a shortened meeting. Couple of areas just to mention. One is the Infection Prevention and Control Board Assurance Framework, really important piece of work that we scrutinise in detail. And at that meeting, we did have the opportunity to see it in full with all the evidence behind it, and therefore we rated that green, and that was a requirement asked of us to give that formal rating. But more importantly, on the second part of the report, we've gone through the detail of, as already been mentioned earlier, the requirement for us to undertake a review, an internal review of the quality and safety of our mental health, learning disability and autism services. And we've talked about this earlier today around closed cultures. And we did focus for quite some time at that meeting around the very detailed evidence that was presented to us as part of the review. The slides are attached to this paper. We thought that was really important, that people had the opportunity to look themselves at the very detailed different sources of evidence and the different people that James Mullins, as Director of Patient Safety for us, undertook this deep dive, but in collaboration with many different people and lots of different sources of assurance, some of which we look at routinely as part of the committee's work, but then there were other areas, and there was over a year's worth of data pulled on lots of different areas that you'd expect to see. And as I say, they're in the slides. And as Krishni's already said, we took the opportunity to talk with governors and talk them through the results and the paper, and they had the opportunity to ask us questions. And then, as Angela's already alluded to, really important, we made the absolute point at the end that this isn't a one-off. It is an ongoing process, and we will absolutely take the opportunity to keep reviewing information as it comes in, as it does, and as new information comes to light, obviously we'll be reviewing it. And now we have the risk Q17. That's a great framework to be able to look at all this information through. So just to give you the assurance that it was given the airtime it needed, we took really good assurance on the information that was looked at this time. However, going forward, absolutely we'll be monitoring very closely across the whole board. So
thank you very much. Thank you, Julia. I don't think the slides are attached. Am I the only one picking that up? I certainly can't see them in Diligent, so maybe it's just that
we did actually have them sent out with a revised board pack. So
Okay.
we'll
So-
make sure they go out, because that is really important. They're on the public website, but we felt it's important to bring them to the board. So that should be.
It may be that that's because I've not updated my Diligent if they've been uploaded since, but I certainly can't see it in Diligent. So it may be in the board pack that physically went out. But thank you. I had seen them anyway, Julia. I just it was just an admin point, just in case anyone else was looking for that and hadn't come across it. But we'll make sure everyone's got access to that. And as you say, it's a published report anyway. Thank you. Any questions or comments, Julie?
Just to say that we obviously continuing this piece of work. We initially did it as asked for mental health inpatients services, but it will, as we roll over the year, we will continue to look at other services, and we're putting a process behind it, because this was actually a very time consuming way of doing it. So we're looking at our data, we're looking at probably a heat map process as well. And as Julia and Angela rightly say, this is becoming an ongoing process, because that's the right way to do it. So we are deep diving into one of our wards, because there's further information that's come to light since the original review. But that's a bit of assurance that we are actually on this all the time. This is a really important piece of work and will become a business as usual piece of work.
Thank you, Julie. I think that reinforces the points that we made earlier about the importance of maintaining a focus on that. So I'm really helpful. So if there's no further comments or questions, we really ask to just receive the report, because obviously it's providing assurance from our Quality and Safety Committee on the committee's work. And thank you for letting me attend. I was there for the last meeting, and it was useful to be part of. And indeed, it was Maria's last meeting as well, so we took the opportunity to say thank you to her. So thank you, Julia. We move on then to our Patient Safety and Learning Assurance Report, and it's paper J, and Linda, over to you.
Thank you, Krishna. Good morning. The paper that's been provided, I'm taking that colleagues have been able to read through that paper. Just to start off by highlighting some assurance to board with regards to our patient safety and learning from death assurance. This information is also presented to the Patient Safety Committee as well as the Quality and Safety Committee, where there's wider discussion as well as a review of those incidents. Of note, where the paper has detailed an increase in reported incidents, I'd just like to reassure colleagues that reporting is a good thing. So when we look at it for any organization, when we see reporting, that's actually evidence of good practice. We then focus on the categories for those incidents, whether it was low to no harm or moderate harm or significant harm, of which for most of our incidents reported, there was actually low to no harm with regards to those incidents. We've provided the 5 top themes that are coming up, and just to mention that there is ongoing work around these themes, and actually that there are some reporting issues associated with those. So for example, with our pressure ulcers, where we've seen an increase, when they're first reported, will usually be reported as new pressure ulcers and put down to NHFT. It's only later when we go back into the information through audit and also through review that we then realize that some of those are not new and they're actually not alluded to NHFT. So that process of audit is ongoing, as well as reviewing all those incidents as quickly as they'll have happened. When we've looked at further areas within this report around some of the other key themes, again, it's worth noting that whilst reporting will have increased in certain areas, but actually the incidence of harm to our patients has been low or no harm at all. So that's just to provide assurance with regards to those areas. There is also ongoing work around our falls management, and certainly that's information that will come back to be presented to the Patient Safety Committee once that information is ready for review. Of note, when we've had incidents that happen through our weekly internal assurance meetings, those incidents are immediately reviewed, and from there, any immediate learning or any immediate mitigations to prevent reoccurrence are immediately picked out and actioned. So whilst the main investigation, if it's declared as a serious incident or a concise investigation, may take longer to review, but actually the immediate mitigations and safeguards are put in place through that process. Moving on to the areas around our learning from deaths. Again, we've provided information within this report which clarifies what we're doing with regards to our learning from deaths, included here the leader reviews and what is being looked at by those leader reviews, so the panels that meet to then go through these cases, including where there's evidence of good practice that is notable and then highlighted. Having gone through the report further along, we've provided further information around the patient safety incident response framework and the timescales that will work to implement this. Our patient safety team are part of a working group that includes ICB colleagues around how this will be implemented, and those meetings are already in place, and we are working with the proposed timescales as well as looking at our own resourcing of what we will need going forward with regards to this. Again, information will be presented to the Patient Safety Committee to review once we've got further detail on how we will then be implementing PSERF going forward. There's a proposal asked to the board at the end of this report, which is really to ask that you accept, if you are assured on the reporting that has been presented, that we continue to be open and that we are complying with our duty of candor. We've put in some mitigations into the risks that have been identified and also provided an update on our serious incidents and concise investigations. So I'm happy to take any comments or questions from this report.
Thank you, Linda. Any comments or questions from colleagues? Julia?
Thank you, Krishni. Thank you, Linda. Just to say that we held the latest Patient Safety Committee on Friday that's just gone, and had the opportunity to ask lots of detailed questions about the information in the report. And 2 really important things. One was the increased focus on pressure ulcer reporting and management and concerns. And I know there's a piece of work happening with Leicestershire Partnership Trust across pressure ulcer work. So that was really good to hear. And the other was just to pick up on what Linda said about how we triangulate information in that meeting. We heard in great detail about how services are monitored for a number of different areas, including incidents, complaints, etc. And how when red flags appear, when perhaps they've had an incident over a number of weeks, how then that triggers a deep dive, deeper look, supportive visit perhaps to that service. And there were a couple of examples given where that had happened, and improvements then and support can be put in and improvements made. And that was a really good piece of assurance to see how it's actually working in action. So when we're talking about this triangulation, it really does happen, and they're picking up quite early on issues and supporting teams with that. Thanks.
Julia, thank you. Always helpful to get the sort of NED perspective as well from kind of attending patient safety or complaints review. So I think that's really welcome. I did have a question myself, if that's okay. It was just, I wanted to understand a little bit more about this. Am I interpreting it correctly that there's a backlog of auditing? It's on the page relating to lapses as a percentage of new PUs. I think, Linda, you sort of alluded to it, but I just wanted to understand the comments about data has only been audited up to the end of July. So are we struggling? Is that a resource issue? So are you able to say any more about that, Linda?
Yeah, so part of it is with regards to the focus for the team. So our tissue viability colleagues have been supporting this audit, and you'll appreciate with increased pressure ulcers, then their priority will be to support teams to manage those pressure ulcers, and then we come back and do the review and do the audit. But aside from that, they need to wait until the information has been properly categorized. Otherwise, the audit will not be meaningful. So that's part of the delay for them to then commence the audit itself.
Okay, so that was the point you were making about waiting for the data to sort of almost be validated first in terms of whether it was correctly identified as new, etc. Okay, that's helpful. Thank you. And are we able to say any more about the Integrated Care Board continuing to highlight the number of patient safety investigations that have exceeded the expected time frame? Is that a concern? And was that discussed at patient safety?
I was not at the Patient Safety Committee meeting on Friday, but it was discussed within the Patient Safety Committee meeting. So we have communicated with ICB colleagues on the delays for some of those investigations, and not all delays are alluded to ourselves. Some of the information we've had to obtain from our colleagues. So I know a recent one that we had to request an extension was due to us trying to obtain information from colleagues in KGH. I know we've definitely got 2 that are out with. So there's various rationale for the delays in those investigations. We did have some where there was a delay in allocation of the investigators, which we were then able to communicate to the Patient Safety Committee, as well as articulate the mitigations around that.
Thank you, Linda. Julie, do you want to add anything to that?
Yes, so I think it was with the CCG, we used to be able to apply for an extension and it wouldn't be seen as a delay. So actually the process changed. I think we did highlight it in a previous version of this to board. So the process has actually changed, whereas we might have said it's a complex or it's out with, even the out withs, as my understanding, are now reported as delays because they've changed the process as we've moved to an ICB. As I say, that's in a previous report, and that's why it's coming through as delays, whereas before we might have said we have so many delays and we've asked for extensions, or we've got a couple of out withs, and usually the out withs are to do with police investigations and things like that. Indeed.
No, thank you, Julie. I do recall I think reporting of the change in process, but it does feel a bit perhaps it's something we need to just think about with the ICB, because actually if there's a pause in an investigation for a absolutely legitimate reason, it seems a shame to report that as somehow delayed. So perhaps that's something we need to think about.
Perhaps we could say that they're delayed, however, they're delayed for these reasons. Perhaps we might put in our report, just for us as an organisation, that is delayed because we got 2 out with. It's a bit like Linda's just reported. That may be the way of displaying it in the future. Would that be helpful?
Yeah, I think so, Julie, because I wouldn't want that to be interpreted as a delay because, you know, we just for no obvious reason. But there are clearly some extensions required, inverted commas. I know we've not been asked to use that, allowed to use that word technically, but because we actually can't progress an investigation, I think that's quite different from our responsibility to make sure that our investigations are done in a timely and efficient manner. So yeah, Angela's, I think, commented putting the reasons and rationale would help, or at least a summary of them. I think that would be useful. Linda, any final point to add before we move on?
Yeah, just to add on, so what the team have started is a tracker which shows what has happened from the date that the incident is actually reported. It will show when duty of candor has been complied with, the allocation of investigator. Will also be able to then show the first contact. So if there's been a delay, perhaps contacting the person involved or their family, we would then be able to put these things in, which will then go to the patient safety committee for the full detail. But what we would do to then provide further assurance here is exactly what Julie said. We would then be able to just list some of the rationale around that, just to say what is actually happening with some of those cases, if that would be helpful.
Thank you, Linda. I think that would be so. Let's agree that, and very good to hear that sort of improved tracking will also give us that clarity about how that's progressing. So thank you for the report. I think there's some, you know, obviously some significant focus on the incidents, and the data is very detailed. So there are some clear mitigations in place, and I think clear oversight also from the Patient Safety Committee. So thank you for the report, Linda. Okay, we move on then to paper K, which is the monitoring safeguards, workforce safeguards paper.
Thank you, Krishni. So this paper has been presented, just a reminder again that the information reported will be retrospective. However, some information Jean has already highlighted around some of the pressures on our workforce with regards to the strikes going into critical incident. And also we've got more strike dates announced coming up next month. So that again has significant pressures on our workforce. We're still living with COVID, so we still continue to have COVID sickness related absences, as well as the flu, which has had an impact over the last few weeks and continues to have that. So really quite a pressured time for our workforce. I'd just like to direct board to the information that we have provided around our staffing levels. And it's important to note that within the different areas, there has been use of professional judgment. And just to explain that, whilst some of the reporting may then appear as though the staffing numbers are low, which is what the roster would reflect, but actually when the capacity, the bed occupancy has been lower, they've used that professional judgment to then not have to request the additional staffing. Equally, where it is above 100%, that is usually where we'd have had to increase observations for patients, where we are requiring additional staff support for those patients. So that's where we've been using that professional judgment within our services, and that's been used appropriately. This information is reviewed in various areas with the Safer Care leads. It's also reviewed within Workforce Safeguards Board and subsequently also reported into the Quality and Safety Committee. I've included within the report the risks that we have within our areas. Some of these risks are not new. These have been risks that have been well managed, and then they've started to escalate once again. So they've come back for citing within this report. Included is also information on medical workforce risks. And again, there's continued efforts from medical workforce insofar as filling up these vacancies. But like anything else, we've had once we've had some areas filled, then actually someone else has resigned and moved on. The other thing of note with regards to our risks around staffing is that as an organization, we've done well in quite a lot of areas where our own staff are being promoted into more senior roles. And once that happens, it becomes a vacancy. So that information is something also worth noting. There's been increased pressure on our staff bank to fill requested staffing vacancies. So they continue to work to try and fill those right up until even after the shift itself has commenced. They continue to try to cover those. There have been areas where the teams have been able to move around their own staff so that you have more skilled staff supporting different areas, and that works really well. Unfortunately, when it comes to us then reporting, that's not easily reflected within our own rotas. Hence, we're looking at how that information can be better reflected within our reports. I've included information on staffing from the different areas, including corporate. We also presented information on our vacancy rates, as well as information around our staff appraisal supervision, which again is discussed in several other meetings that we have within the organization. It's also looked at quite closely and reflected on within the executive management board of the organization. I'm happy to take any comments or questions, and there is an ask at the end for board to just review the risks that we have mentioned and the mitigations that have been included within this report. Thank you, Krishna.
Thank you very much, Linda. So a couple of comments or questions. Saki?
Thank you, Linda. Just a couple of observations. I'm not sure whether they're typos, but on 114 in my pack, winter plans, it has the date as January 22, and also on 116, school age, again, it has January 22.
So I don't know whether that's presumably just, so it's worth noting really that the dates, if they are incorrect, need to just be reflected in the minutes as noted. Thank you, Saki. Richard?
Yeah, thank you. Thanks, Linda. I think the narrative's helpful, isn't it? Because I think it's illustrating a lot of the pressures that are then translating into sort of financial pressures that exist. I just wanted to pick up one specific one in the Community Healthcare Directorate. It talks about specialist palliative care and some concerns raised by staff. I just wanted to add myself, Julie Shepherd, and senior HR representatives have met with the staff twice now. I think the board's aware of the kind of option appraisal around Cransley, and that's tied up in some commercial negotiations. I think also a number of the staff who've left actually have had promotions as well. So there's a range of reasons really for some of the change there, but I just wanted to add a bit more flavour to that one. And we have, Julie and I promised to keep the dialogue going with staff so that we keep them informed. Obviously, that, as I say, there are some commercial negotiations going on, so we're trying to work within that framework. Thank you.
Thank you, Richard. That saved me asking that question because I noted that a meeting was due to take place, and we're all, I think, for those of us obviously aware of the Cransley related negotiations on the lease, etc. It was just highlighted previously, so thank you for commenting on that. Julia?
Thank you, Krishna. I think I echo what Richard's just said really about really welcome the detail in the report, because I think it just gives us collectively a really good understanding of some of the pressures and relating to some of the risks that we face. I was just going to highlight, for example, adult community nursing, where we've already heard this morning about the importance of diabetes teams and prevention, and there's an impact on increasing numbers of diabetic referrals, etc., to this team, and particularly around risk number Q6 that we talked about earlier, which was around excessive demand and in access to community adult services. Of course, this is one of those, and the mitigation in the second column talks about turnover has slowed, so I really welcome that, because that was a real issue before, and that there are a couple of other mitigations in place. But I think this service for me, it just particularly highlights all the things we've discussed at the board this morning, and how all those things come together in a very pressured service, as with the others, but good to bring it together in a risk-based workforce report where we can really triangulate some of that information. So we recognise the pressures, I know they're being monitored, and lots of work going on behind the scenes. So it was just to highlight particularly the importance of keeping this on our.
Thank you, Julia. Yeah, really important reflection. Angela?
Yeah, thank you. No, really helpful report, Linda. I just think it would be something for us to reflect on. How do we capture sufficiently going forward the changing nature of people's workloads and the sense of what's changing for them? So when you go and talk to staff, they might say the acuity is increasing, or actually the people we see are different, and it would just be good to get a sense of how we do that. I know people are talking about those things, but how do we capture that so we can anticipate some of the changes in our workforce that might be needed? And then secondly, just to sort of the final part of our quality section, I wonder whether it would be useful to draw together the critical incident. And I know Linda was very much focused during that period on any immediate incidents or learning or anything that came through. I think it'd be really useful just to draw all those bits together, obviously through the strategic exec, but also through committee, just to make sure that we can understand that we are all fully sighted on anything that happened during that period, whether it was staffing levels, incidents, or anything, please.
Thank you, Angela. So you're suggesting that we a sort of lessons learnt type of report. That might not be the absolutely accurate, but certainly reflecting on what happened and reviewing any learning from that. Going back to quality committee, yes. So quality committee can assure us. So
a particular focus, I think, on how was safety maintained, mitigated, because obviously that was the focus through the period.
Thank you, Angela. And just on that broader point, I mean, I think one of the things that Richard might have touched on perhaps at a previous meeting was we don't there isn't a sort of acuity measure. Am I right in there's no acuity measure in mental health? Is that right? Have I heard that correctly? And you know, I do, if that is the case, then is that part of what, you know, Angela, you were talking about? Is that understanding, you know, acuity in our services and how that might affect workload?
Yeah, and I think it's important to say that there's no national measure. But clearly, if you talk to any mental health service, whether it's our trust or any other, they will tell you about increased acuity. And that is, you know, if you like, displayed in lots of different ways. But because there's no national measure, you can't do comparables in the same way as you might want to. But obviously people describe it, and Anne, I'm sure, would be able to add to that. But yeah, I know nationally they are looking at that to understand that in a different way as well, Krishni.
Thank you. Thanks, Angela. Anne, do you want to comment on that?
Yeah, I was just going to say, we've only got really sort of nationally some really crude measures, like how many people have been placed on the Mental Health Act in comparison to before, and it doesn't really get to the nub of how it feels different. I think that's what Angela's describing. So not only are we seeing people who appear to have become more impacted by their illness quicker, but also lots of differing presentations related to how people are living in our community today. And I think that's the piece that we're trying to make an understanding of in the collaborative and in the different teams in the trust. But I think it does we're raising it up with the regional colleagues, because it's really hard to define when there's not a national sort of benchmark. So we will be pushing that with our regional colleagues to sort of see how we can do that together. And I think the East Midlands Alliance is something that would really help us with that.
Yeah, that's a really good opportunity, isn't it, to reflect that across the broader footprint, because it's obviously a common challenge, and there seem to, you know, there's clearly common pressures out in, you know, I think there was a an example from another well-known mental health trust, about out-of-area placements and the pressures within their system, and that seems to be a common experience around in the mental health arena at the moment. So anything we can do to influence that, I think, clearly would be helpful. Julie?
I was just coming in and add and saying, for our inpatient services, as we do work monitoring workforce safeguards, and we do it every 6 months at the moment, we do use mHost, which is a tool that does look at acuity and dependency on our wards. So we have got that to add into some of the triggers that Anne mentioned. At the moment, there's nothing for mental health community services. But we've always talked about district nursing, haven't we? And we've had challenges with district nursing, where there is a workforce tool now out for district nursing, and we will hopefully start to see us using that. We're just getting trained within the organisation on how to use that tool, and then we will be using it as part of our workforce safeguards. So whether something will come out through the workforce safeguard work on community mental health, I don't know. But certainly we've got something for district nursing now going forward, which I think is a positive.
Thank you very much, Julie. So clearly we are required, this is another report that we're required to publish as per the National Quality Board guidance. So it's for us to acknowledge, I think, as the report highlights, the risks that have been described and all the mitigating actions in hand. And we've touched on some ways in which some tools and other things that we're obviously using to understand the acuity and other issues that we're dealing with at the moment, but more to be done, it sounds like, in this area. But thank you, Linda, for the report. And if you could just have a look, I think there was a couple of comments just about addressing those dates and making sure we've got the dates right, but otherwise it sounds like the report is appropriate for publication. So thank you. Okay, and of course we mustn't lose the action around a review of the critical incident and learning from that, which Angela highlighted. So we move on now to our finance and performance section. So first of all, we have assurance reports from audit and performance. So Saqib first.
Yeah, I draw your attention that, as I was saying, everything is going in a good direction. Obviously, we want to make sure that this year's audit is completed on time. Obviously, due to sickness last year, we had some issues, but I'll liaise with Richard to make sure we have no issues like that. In terms of our internal audit plan, that's progressing well, counter forward as well. So if anyone has any questions, happy to answer.
Thank you, Saqib. Any questions for Saqib? No. Okay, so we'll just receive that report. So thank you very much. And then over to you, Scott, for the Performance Committee report.
Yeah, thank you, Chair. I'm just going to bring out a few points. So we're obviously going to come on and talk about the integrated performance report in a moment, so I won't say too much in that area other than to say that the committee had quite a good discussion, actually, as reflected in the notes, on the utilisation, the implementation of virtual ward activity. Quite a positive conversation. We're all, at the time when the committee took place, we were actually sort of surging beyond our contracted level of 250 virtual beds, but I think we took some good assurance from the fact that that was being managed with strong grip and control, so that was a positive. Just wanted to bring out a piece about agency spend. So obviously we are above plan, our agency spend quite significantly, but we've chosen to mark it as an amber on this occasion, and part of the reason for that is that it's twofold, really. First of all, quite good evidence again of grip and control in relation to how we're managing that expenditure, albeit that we are above plan. We are showing an improved position year on year from our 21-22 position, which actually sees us buck the national trend. That's very much out of step with other comparable trusts up and down the country, so worthy of note. And I think obviously quite a lot of focus, as the minutes reflect here, on ensuring that we minimise the utilisation of off-framework agency spend, which is clearly a big pain area for us. The only other area that I was going to bring out, Chair, was in relation to the financial performance for the Trust. So obviously we've marked that as a red. We are obviously we are a constituent part of the overall system forecast deficit of £35 million, and our element of that is that we are forecasting a £9 million deficit. There is quite a lot of challenge to land that £9 million position indeed. Judith and I have picked that up offline and had a conversation about it as well. However, obviously, if we were to do anything to step away from that, that would reflect us impacting negatively on the system's position. But it's important that I think we make committee aware of the fact that there's risk to hit that £9 million position. And it would be inherent upon us to just bring that to the board's attention whilst we're having this discussion now. But that was it, Krishna. That's all I wanted to pick up on.
Thank you, Scott. Any comments or questions on that at this stage? Okay, thank you. We move on then to the integrated performance report, and we're looking at Dave for that.
Thanks, Krishna. Thanks, Scott. So just in terms of some highlights, well, first of all, just draw people's attention to the report itself and how it's evolving. So next time we come together as a board, we should be able to see our community data in SPC format in a bit more granular detail. That's part of the work in progress with the BI team. Areas to draw your eye to, I guess, remain Advaria placements. We are seeing the outturn on that kind of improving. That's also very important to our financial position, but also we talked about the critical incident earlier. We had a number of patients who we were unable to discharge during that critical incident, which amounted to the equivalent amount of patients who were out of area. So Christian and I made the point at a recent ICB development session that when we're in those kind of pressured environments, that we think about parative esteem across the board to make sure that when we're looking at discharge, we think about mental health discharge as much as we think about acute patient discharge, because they both have an impact on service flow and delivery. Our MSK, there's quite a detailed bit of information in terms of the recovery plan on MSK. Fair to say it's on trajectory to fail, as you'll note. That's for significant reasons relating to estates, but also increases in elective activity obviously have a corresponding impact in our MSK capabilities. So we'll be looking at that in detail in the planning round to make sure we're in a good space for 23-24. In terms of good news, we can see our CYP eating disorders routine has improved. Advaria, as I said, begins to tick downwards. And on waiting times, we have got some data quality issues which we're looking at as part of the waiting list review work that we're doing anyway. So we'll update performance committee and ultimately this board in due course when we're a bit clearer on those parameters of that data quality. So just on the dashboard then, before I hand over to Richard, just to talk us through some of the finance elements. Linda covered helpfully some of the workforce analytics in her paper, but we are, just to reassure people, the vacancy number increase in this is broadly attributable to posts that we have resource for that have come on stream for which we are recruiting to. So it is not that we have increased vacancies as such, it's our capacity is now growing in line with the long-term plan trajectories. Hopefully, I think turnover is beginning to tick downwards, and sickness overall. We're not seeing huge volumes of COVID sickness, but coughs, colds and flus are driving the majority of our sickness. And of course, some of those will relate to kind of stress and burnout too, which we continue to review through the wellbeing group. On the yellow highlighted areas in dashboard show where we've got to in SPC charts for some of our performance. Some of those other areas will come on stream over the next few months as we finesse and improve the model. And I think just to draw kind of some of the failure lists, we still feel like IAPT is not going to land in a good position this year, but we do believe the prevalence trajectory is changing for next year. So that should make our capability to meet the demand. As I say, it's a supply issue rather than a demand issue in IAP services. So bringing the expectation of the numbers of people down, the prevalence down, should allow us to be able to meet that in a more robust way. So that's promising. And I think that's going to be reflected nationally, actually, because quite a lot of areas had overstated prevalence for IAP services, which we know about. Recovery remains strong. And apart from that, I will hand over to Richard for an update on the finance bits.
Before Richard comes in, Richard, I do want to hear from you on the finance piece, but I just wondered if it might be helpful if there were any questions on the dashboard, the performance elements of the KPI elements of the dashboard, whether anybody just wanted to ask any questions whilst it's fresh. Scott?
It's not really a question, Krishna. I just wanted to make a comment. This seems like the most appropriate place to do it. I just wanted to again draw the board's recognition to the continued development of this report. You know, over the sort of last 9 to 12 months, largely under Dave's stewardship, but also with input from AG and many others. You know, we've seen the report really come on leaps and bounds, and whilst it might not be giving us the information that we want to hear in relation to some specific aspects of performance indicators, the more detailed adoption of SPC charts, you know, and all of the other, you know, just even the cosmetic look and feel of the report is allowing for much greater richness of discussion on behind the issues, you know, and I think that's really important to recognise for us here. The challenges that are here will, you know, to some greater or lesser degree, always remain, but it feels like we're able to more forensically put our finger on the button, you know, and get into the depth of the detail. So thank you to Dave and to others for continuing the development of the report.
Thank you, Scott. Thank you. I just had one question, if I may. Under MSK, might be an issue for Chris. There's reference to significant delays in recruitment processes, which seems sort of out of kilter with all the work that we've done on enhancing our recruitment processes, really. And I just wondered if that's a blip in relation to that particular service, or there's some other problem that we need to understand. So it's under MSK and it describes recruitment processes that began in April 22. Any comments?
I've not had that flagged to me, Christian. That does sound unusual, so I'm happy to take that away. I don't know how that was reported up, but certainly that's, you know, the recruitment processes we've done a lot of work on, and we are putting a lot of people through. So I'm happy to take that away and investigate it.
Great, thank you. It just seemed a bit of an anomaly in relation to work we'd already done on improving that. Dave, did you want to add anything on that?
Oh, just for AHPs, I mean, we talk about AHP international recruitment as part of the recovery plan in MSK. I agree the process does need a further look if it is the process, but also the recruitment of AHPs is actually difficult. They don't tend to join banks necessarily, they'll join agencies. So it is a different kind of spectrum of professional recruitment, I think, but we can look into both angles, Christian, and come back to you.
Okay, thanks, Dave. Thanks, Chris, as well. So over to you, Richard.
Thanks, Christian. So in terms of the financial position at December at month 9, the trust has spend in excess of income value of 11.8 million. And as Scott set out, we are targeted as part of the system deficit to retrieve that back to a 9 million overspend by year end. Now, we have identified around 10 million of mitigation actions. They are largely non-recurrent actions where we're reviewing and seeking to eliminate risks that we've identified previously, where we've provided for risks that we're now trying to negotiate with partners or take internal action to remove. I think just some context for the board, since our operation as a foundation trust over the last 14 years, we've only found ourselves in a deficit 2 of those years. It is a breach of statutory duties. All trusts are supposed to break even. So just want to make the board aware of that. Clearly, as part of the planning for 23-24, we're looking to seek to redress some of the issues that I've identified, and we've done a very detailed amount of work around what are the key drivers for the deficit, how our workforce has changed since the pre-pandemic period, and also, as I talked about, where we are delivering increased activity and productivity compared to that workforce growth. So we understand fully the drivers for the deficit, and obviously shared that with partners across the system. So there is a common level of understanding, but clearly we are in a challenging place for reasons that are well versed, I think, around demand pressures, inflationary pressures, workforce, that people are well aware of, obviously the cost of living situation that we're in currently. So it is challenging, and we have still got work to do to get to the 9 million that isn't secured, and that's the focus that we're on over the next couple of months.
Okay, thank you, Richard. Any further comments or questions about this? I mean, clearly there will be further discussions in our meeting later, but we just wanted to give the opportunity for people to ask any further questions. I think that the position that you reported is the position that has been agreed with the system, hasn't it, Richard?
Yeah, that's right. Yeah, so our other partners are in similar challenged position, which is why we end up with an overall 35 million deficit. That has been subject to escalation discussions with NHS England and across the ICB, and that is the target the system has agreed to reach by the end of the year. I mean, again, there are risks, and obviously the critical instance that Jean was talking about earlier of added costs into our system, and they weren't known necessarily at the time. But we have got a good track record, so we need to enact the same things that we've done in the past. But that, as I said, it isn't without its challenges. It's very challenging at the moment.
Yeah. Thank you, Richard. Okay. Any other comments or questions before we move on? So, I mean, clearly, I don't think we can, we're, as Scott said, I think the reporting is very clear and developing well. It is a very challenged position, and I think we all recognise that. So we're not necessarily got assurance on all of these areas that I think we're doing. We know we've got the actions in hand to manage these and mitigate against some of the challenges and risks that we've highlighted. But it is a challenging position, and I don't think we can underestimate that as a board. Okay, Angela, anything you want to add before we move on? No. Okay. Thank you. So we move on to the final section of our agenda. We've got a few items that we need to just receive that are sort of not routine items, if you like, other than the Leicester Partnership and our group report. So first of all, paper O, which is our emergency preparedness, resilience and response report. Paper O, over to Jean, please.
Thank you, Chair. So this is a report that we bring annually. This is around our compliance with the EPRR core standards. So we are required to self-assess, which is then reviewed by the ICB and then reviewed by NHSE regional colleagues. I think what's important to note this year is that there have been a change in the standards, both standards being added or amended, and also the expectations in terms of evidence to comply with those standards. Unfortunately, I'm not sure why, but that wasn't actually communicated with providers until the assessment started. So that did leave us in quite a tricky position in terms of our ability to ensure that we maintain the status that we have. So we have scored partially compliant overall with 7 out of the 53 standards and non-compliant with 3 out of the 53, which leaves us as in a partially compliant position. The report does provide the actions that either have been taken or are being taken to ensure full compliance going forward. In addition, we have a workshop planned on the 13th of March, where we're going to go through every single core standard, all of the different frameworks, and ensure that we are satisfied as a group as a team, that we will be in a much better position by the end of the summer is our intention. So we really want to make sure that we are providing that platinum standard around EPRR, because it does fall under that safety banner that, of course, the board would be fully aware that we have some real key drivers and changes afoot on that. So that's where we are. So it's a disappointing position from an HFT, but there have been some mitigation reasons as to why we are at the position we're at.
Thank you, Jean. And just to clarify, the workshop is an internal one, is it?
It is.
It
okay. is, yeah. It's a workshop, but then we're also bringing in Richard Jarvis, who's the EPRR lead across the system, towards the end of the workshop, just to make sure that we have that communication and awareness across the system. What we will then take from our work with Richard is perhaps into the LRF, which is the Local Resilience Forum, some work that we can undertake across the system as well.
Thanks, Jean. Any questions or comments? And the only thing I did want to pick up is there's a reference to, I think, a committee where this is going to feature in terms of committee work plan. Can't remember which report I picked that up on. Was it because the joint committee was looking at this? I'm not absolutely sure. Apologies, I should have noted. But there's a reference in an earlier assurance report to committee work plans. I don't know if any of the committee chairs have had a question about where this reports. Is that why it might have come up? If none of that makes sense to anyone, I'll just pick it up with Richard offline. Richard?
Thanks, Christy. Yes, I think it was just us wanting in the process of refreshing the work plan, particularly for QNS, to confirm where this is going to report to in an insurance perspective, as we have made a slight change. And I think, as you say, there was potentially an anomaly in terms of how we were referencing the assurance process in another report. So what I'll do is take that offline with Jean, with Julia, and take that through the work plan review process for QNS so that we can confirm the position.
Okay, and maybe that can start with just a report back to QNS if that's the appropriate forum for, you know, the output of the additional work that's going to be done by the period that Jean indicated, which I think was sort of summer, really. Because it would be helpful to have some assurance that we are more satisfied with our compliance at an appropriate point, and I think it'd be useful to receive that assurance through the appropriate committee. Thank you very much, Jean. So I think we note the position. It is what it is, isn't it, at the moment? But the work is clearly required to get us to a compliant position, as we have been in the past, and I think that sounds like a shared challenge across the system. So one we need to just engage with partners on as well. So thank you for bringing us up to speed with that. The next item, paper P, is the proposed changes to the NHFT constitution. Colleagues who attended the Council of Governors will be aware of the rationale for this, but useful just, Chris, I think, to highlight the background.
Yeah, I think Richard's going to take us through this.
Okay.
Thanks very much, Chris. So yes, this paper represents the combination of two key pieces of work really that we've been undertaking in partnership with governors over the last few months. And I'd like in particular to thank governors and Peter Howie for their significant contributions to these pieces of work. So as the board will see, the first area of work relates to the council composition. We've taken the opportunity following the effectiveness review in the summer to review our council composition in terms of the changes in our population and the new operating context, the world of ICBs and ICSs. And the other piece of work relates to lessons learned from recent governor conduct cases and just refreshing our sort of suite of documents and our method really for supporting governors to function well as members of the council. As Christian mentioned, these two issues, I suppose, the paper was considered at the Council of Governors and endorsed earlier this month. And you can see within the details of the proposed changes to the Constitution that will be required to implement the recommendations that governors had suggested that, subject to the board approving this approach, that we just take the opportunity to just slightly reposition Annex 6 so that the narrative flow starts with our intention, which is to positively support and encourage good conduct, and then finishes with what we would do in the rare instances, hopefully, where we would need to intervene to make some corrections. So I apologise for the length of materials in the pack. Of course, it was necessary to share with you the details of the proposed changes to the Constitution in order to seek your approval. So as you can see there, we've set out the specific changes, both in the first instance to the COG composition, secondly, then to Annex 6 and the governor conduct process, and then finally just seeking your support to then post-meeting really pull that all together so that we can then publish it on our website and share a final version with NHS England. So I'll happily take any questions on the detail, Krishni, and yeah, really seek your approval for those changes. Thank you.
Thank you, and just as Richard said, I would absolutely endorse his thanks to the council. I think this was some significant pieces of work which governors engaged in, but also non-executive colleagues were actively engaged in as well. So there's been a really good contribution to these pieces of work. And you know, it was really welcome that the council approved all of these changes and endorsed them. So just want to make sure the board has the opportunity to do the same. But if there are any comments or questions at this stage, absolutely welcome those, but particularly for colleagues who are less involved in those conversations. No, nothing to. Oh, Robin. And endorse them. So just want to make sure the board has the opportunity to do the same. But if there are any comments or questions at this stage, absolutely welcome those, but particularly for colleagues who are less involved in those conversations. No, nothing to. Oh, Robin.
Coming later to this process, obviously a lot of work's gone on, and the council itself has gone through this, but I didn't get the rationale for the changes, I'm afraid, from the paper that's presented. I didn't understand why the changes that are being made are proposed and what the history is. So it was just a reflection really as a newcomer to this process. I didn't feel that the paper identified for me a kind of compelling narrative as to why these reduction in the numbers were required in the particular categories. But given that the council has approved it, I don't want to make any more of it than that, really.
Thank you, Robin. I think that's probably Richard. Do you want to respond, or it might be helpful to give some background to Robin as well, because there's a long history behind certainly one of these changes, which was actually something that the council asked for itself, for a significant review. Richard, do you want to make
thanks, Krishni. Yes, apologies, Robin. I took the decision not to include all of the case for change in this report, but linked to the council paper where some of that detail is contained. Really happy to catch up with you offline on this. As you say, it has been a conversation we've been having with the governors over several months, but certainly in the short term, the Council of Governors paper, which is linked in the report, does, I think, more clearly set out some of that case for change and the origins of this piece of work. But yeah, really happy to meet you outside the meeting to pick up any questions.
Thank you, Richard. So I take it that we are happy to endorse the changes. I'm not seeing anything to the contrary. So I think we can take that. I'm just observing, Richard, that there's a comment in a message come up which is saying that the recording has stopped. So I'm just highlighting that to you. I don't think we can stop the meeting, but I'll just make you aware of that in case that's a problem, technical problem of some kind. So we'll endorse that. It's also worth saying that there's some ongoing work that the council, I think, want us to do, and that's pieces of work that we felt we should pick up when we've got. We are going out to election. It's just worth reminding the board that the elections will now be based on this revised composition. Which is really a streamlining of some of the constituencies. And we'll be going out to election on that basis, and then engaging with newly appointed governors from around sort of end of April, May onwards. And actually at that, as part of that, we will also be looking at things like governor well-being and welfare. And also, I think the other piece of work that we talked about was the board and governor charter that we had previously developed, but we thought would be better suited to waiting for new governors to be part of that piece of work. I think that's right, isn't it, Richard, in terms of
it is indeed
timescale. Great. Okay, well, thank you very much. So we'll take that forward. Obviously, the corporate governance team will need to finalise and publish the revisions following the board meeting, and then the process, the procedural changes that have been supported will then be put into effect. So that is quite an important point, and one that the governors very much wanted to take forward. So thank you for that. The final item we have is paper Q, which is the group highlight report. And it's over to David Williams for this.
Lovely, thank you, Krishni. So we have the report in front of us, and I'll take it as read. There were a couple of bits I was just going to highlight, providing a bit of context. We've already touched on earlier today that we've got our next joint board workshop on Monday of next week, so an opportunity for us to all come together and work through some learning. And I think that sharing of learning is really invaluable, and wanted to just also highlight that both deputy chief execs are creating the space for round tables in order to bring people together from across organisations in order to share learning and develop new solutions for ways of working. So that's another way of building that connection across the group and ways of working. And then in the appendix to the highlight report, we've also provided some additional information about some of the other services that are already working together, learning from each other, including 0 to 19, children's eating disorders, our procurement functions, learning and development, and also the patient safety things that we've talked on today. So there's a highlight report there where all the areas highlighted have got actions in place, and we'll update. Happy to pick up any queries or questions.
Thank you, David. And I think we're going to be sort of continuing some of the conversation about joint priorities, etc., on Monday, in fact, at our joint workshop, which I think will be helpful, and certainly obviously take forward our discussions already on our Together Against Racism initiative. But any comments or questions on this report at this stage? I think not. So we're really just asked to approve the report. I mean, it's obviously important that the board is cited really on the discussions that are taking place in our joint working group with Leicester Partnership, and that's the reason why that report is here, and obviously goes to the Leicester Partnership board as well. But it's great that we'll have the opportunity together on Monday. But I also want to take the opportunity to I think congratulate Mark, who has been who is the deputy and Dave's counterpart at Leicester Partnership. I think he's been successfully appointed to a role within the East Midlands Alliance. So that's Derbyshire, I believe. So that's
appointed to the chief exec position, Derbyshire Healthcare, which is a mental health trust provider in our alliance. So yes, it's really good that Mark's been successful and that he's still within the East Midlands, because it means we continue to work with him as we do with the other partners. So yeah, really pleased about that.
Yeah, and it's I think it, you know, important in terms of talent management and progression that these, you know, people are able to take up these opportunities. So whilst always a loss to us in our group setting, I think it's a great reflection on people's progress. So congratulations to Mark, and look forward to Monday. So thank you, David. I think in terms of items for information, we've only got our board declaration of interest, and we'll go through a process of updating those. I've noted the need to update a couple of things myself on there. So just remind colleagues that we need to make sure we keep that under review and submit any updates in year where appropriate. But obviously we also undertake an annual process of review, which will start soon. I've got no other business that I particularly have been brought to my attention, but we have got a few minutes if anybody wants to raise anything. In fact, we're quite well ahead of time, but that's not an invitation to have a long discussion about any other items of business, as I'm sure colleagues will be very happy to have a slightly longer break in between this.
Just to say to Robin, don't fall for it, Robin. This isn't typical.
No, I don't think it is.
No, it is, but we have been relatively efficient in recent months, I think. So so that's good. I just did want to say one of our staff governors commented on, has dropped me and myself and Angela and others a note just to say how much he enjoyed the patient story and how useful it was to hear that and recognise the impact of the disease and diabetes. So I think that's good because we don't have any feedback on these things live, but it's nice to note that people found that patient story really useful, as we did, who were observing the board. And actually, if I could also encourage you within your networks to promote our diabetes event, and which actually I should have highlighted, was in my chair's report, but our diabetes event and our CAMS event, both of which we're actively promoting. And I'm hoping actually to attend the CAMS event with Naomi Eisenstadt, who's our ICB chair, because she obviously, it's just a good opportunity to highlight the services that we're offering. But do please promote that within your own networks as well, because they're available to members of the public and will be available for people to watch afterwards as well. So on that note, I'll bring the meeting to a close. Thank you to everybody for all their efforts as ever. And we are very grateful to staff in what's been, I think, a very difficult period over the Christmas period, particularly, but also the critical incident. We know everybody's trying really hard to maintain, the high standards we aspire to on behalf of our patients and community. So thanks to everyone for that. I haven't conducted a snapshot review, but if there are any points of feedback, this is the moment before I close the meeting. No, I think everyone's just grateful that we finished a little bit earlier. So we have our private meeting starting at 1 o'clock. So everyone gets a slightly longer break in between meetings. But thank you again, everybody, for joining, and to our observers as well. I'll close the meeting. Thank you.
Thank you.
Thanks, Christian.
Bye.
Thanks,
Take care, everyone. Bye-bye.
Bye.